Hello everyone, my name is Carson Smith and I'm a second year general cardiology fellow with Beaumont Dearborn. Here presenting a case along with my mentor, Dr. George Nahas. We have an unusual case of COVID-associated left ventricular thrombus. It was complicated by acute limb ischemia. And as you can see, it's kind of an interesting presentation of a known phenomenon with regards to COVID coagulopathy. As you'll see, it's well known that there's an increase in thrombotic events. However, what was interesting about this case was, as you'll see, the patient didn't have a lot of the typical risk factors, and it was quite a dramatic presentation, all things considered. So with that, let's get into it. Of course, also would like to mention neither Dr. Nahas nor myself have any financial relationships of note. And so with that, let's go ahead and introduce some of the factors that make this case unique and some of the background there within. One of the most commonly observed features of COVID-19 are an increase in thrombotic events. Although a definitive mechanism remains unclear, there are multiple potential causal risk factors that have been demonstrated in the literature. However, one single cause has not yet been elucidated. Things that have been purported are an inflammatory cascade, endothelial cell dysfunction, platelet activation or dysfunction, and/or complement activation have all been hypothesized to play a role. Classically, thrombogenesis occurs in our COVID patients in the form of DVTs and sometimes in the right heart chambers, which can then cause pulmonary emboli. We present a unique case of COVID-associated left ventricular thrombus that presented actually as an acute limb in a patient with an otherwise structurally normal heart. So moving on to the case itself, we present a woman, 61-year-old, past medical, did have a couple cardiac risk factors, in particular hypertension as well as type 2 diabetes. She presented with systemic symptoms of fevers and chills, additionally decreased sensation down the entirety of her right leg, and purple toe discoloration. On preliminary labs, CBC was notable for normal eosinophil count, hemoglobin was stable, BNP was also normal. However, as a pertinent positive, the patient was found to be COVID-19 positive with severely elevated inflammatory markers with a CRP of 150 and an ESR of 54. At that time, we performed an arterial duplex on the patient, and she was found to have an acute thrombus in her right lower extremity. She was taken for emergent thrombectomy and balloon angioplasty of the right common femoral artery with successful restoration of blood flow. On 2D surface echocardiography, it's kind of interesting. We identified the source as an apical thrombus in the LV. However, what was really quite surprising was that there were no focal wall motion abnormalities, including the apex itself, and there was no trabeculi at all, or anything else to suggest a potential etiology or how this thrombus may have formed within the LV. Following the procedure, initially the patient was started on apixaban by the primary team and subsequently changed to warfarin by our team. Unfortunately, due to non-viable tissue, the patient did require a transmetatarsal amputation of her third and fourth digits. And so to review, we have a patient who was found to have an acute limb that was due to an LV thrombus in the setting of an acute COVID-19 infection. However, her echocardiogram didn't show any of the signature hallmarks that are associated with LV thrombi, including anterior wall MI, as well as LV thrombus or severe wall hypo or dyskinesis. These conditions allow for local hemostasis and subsequent thrombogenesis. However, it's anticipated that a normal LV with normal systolic function is a high-pressure, high-flow chamber that should discourage this thrombogenesis, which is not what we saw in this patient. We were unable to find any similar cases in the literature to anything like this. It's thought that her COVID-19 infection led to a high inflammatory state and subsequent hypercoagulability that allowed for this thrombus to form at all. And therefore, because she had preserved systolic function, that the clot was not only mobile but ejected from the LV due to normal contractile function of the adjacent walls, and therefore in this patient caused an acute limb. So what this case demonstrates is that, potentially even in the setting of an acute COVID infection, formation of LV thrombus is possible even in the absence of pre-existing LV structural abnormalities.